Good deal. So welcome everyone. My name is Ellen Barra, and I'm a specialist with our Provider Outreach and Education Department for WPS Government Health Administrators. With me on the call today is Jennifer Boniface. She is also with our Provider Outreach and Education Department, and she is one of our clinical nurse analysts. So she will be watching the chat. She'll be placing some information in the chat for you. And then she'll also be assisting with any questions that I may not be able to answer. So the first slide that we have there for you is our disclaimer. We have provided this education as a tool to really assist you in billing correctly for your Medicare patients. Medicare rules, however, do change often, and the CMS guidelines are the final determinant of coverage along with your documentation. We'll provide responses to your questions based on the facts that you provide to us, but again, the Medicare rules and your documentation will determine the final coverage. CMS does prohibit recording of this presentation for profit-making purposes. So if you're recording, if you're doing screenshots, we would ask you to stop. We are recording this, and this will be available, barring any technical difficulties with the recording. It will be available both on our website, under our training center, and then under Encore presentations. In addition to that, it will also be available on our YouTube channel. So here are some of the things that we're going to talk about today. Number one, I want to make you aware that one of our clinical nurse analysts recently completed webinars on medical review findings on wound care documentation. Now, that presentation did not deal specifically with podiatrists. However, she did do two separate webinars, one kind of going through the findings and then one also dealing with documentation. The documentation that she happened to use during that presentation did deal with mainly foot care situations. But you can go and you can look at the encores of these presentations. They are available on our YouTube channel, and I believe that they are still available on our website also. I placed the title of both of these encore presentations within your resources page, and that's at the end of the presentation. We're going to touch on some of the same information, but we're really not going to be repeating the information that was contained within those webinars. We are going to provide education or information contained in both the local coverage determination or LCD, and also the local coverage article, LCA, and we have a link to both of those for you within the resource section. We're going to provide information for you on the use of the procedure codes 97597 and 97598, and we're going to provide some information on skin substitutes and documentation. We did have a pre-submitted question within the last day or so asking about where to place the UPC code for skin substitutes on a facility claim. This question would be better answered by our customer service area. So we encourage you to give them a call. You can submit an inquiry through the portal, whichever you choose. The next slide simply has the acronyms that we're going to be using as we go throughout this presentation. We wanted to kind of gather them all up in one spot for you to use as a reference. So the previous education, just like we have stated, dealt with medical review findings. Our medical review area conducted a TPE, which is a targeted probe and educate session or processes on wound care procedure codes. Now, not all of the codes would actually apply to a podiatrist, But during that, they provided education on the medical rules for wound care in general, and then again, documentation for those. If you're part of the TPE process, you do want to take advantage of the education that you can receive from our nursing staff in the medical review area. And then if they are recouping claims, setting up overpayments on things that we have paid previously, or are denying services, they do provide you with information on the reasons behind those denials or recoupments. So I do encourage you to pay close attention to the information that they are providing to you. So here are just some wound care basics, and you can see here that the patient must have one of the following conditions. Now, it says it must be present, obviously, and then it also has to be documented. You know, the old saying about if it wasn't documented, it wasn't done is very valid for Medicare. Obviously, our nursing staff who are reviewing your claims, whether it's from WPS, ourselves, whether it's another medical review contractor, they're not looking at your patient. So the only thing that we have to go on when we're looking at documentation is what you have contained within the medical record. So the documentation must include and must show the type of the wound. And then the documentation must meet one of these items that's listed on your slide. Diabetic foot ulcers, you'll notice, is listed there. Neuropathic ulcers is listed there. Complications of surgically created or traumatic wound. If you, for an example, have to do an amputation of a patient's toe or something like that, and there are complications from that, that's the documentation that we would need to have. Now, this presentation, as the title showed you, is provided for podiatrists specifically. And so that's how we're going to approach this wound care information. So your documentation needs to show the location and then the specific information on the status of that wound. Standard wound care, you'll notice the first one there is optimal nutritional status. As a podiatrist, you may not necessarily be responsible for that portion of the patient's care. Developing their nutritional status, maintaining the patient's glucose control, etc. That could be taken care of by their primary care physician or an endocrinologist, something along those lines. If you're not responsible for this activity, then you want to make sure that you're working with that patient's other physician to promote better nutritional status. Some questions that you could ask: has the patient received diabetes self-management training? Has the patient received medical nutrition therapy? You want to work with that primary care or other practitioners in order to receive this information so you can support what it is that they're doing in order to maintain that glucose control, to retain and encourage that optimal nutritional status. You can also assist with this in encouraging the patient on what they need to do to increase their chances of better healing. We know if the patient's nutritional status is not good, if they're not following the recommendations that you're making, that wound care and the healing of that can really suffer. We've provided you a link in the resource section to our local coverage determination, which is L37228. And then we also have a local coverage article, and it's a coding and billing article, which is A55909. And again, the link is in your resource section. These both provide great information on what WPS is going to be looking for within that documentation itself. So when we're talking about kind of a cohesive, comprehensive care for that patient, that goes along with that glucose control. You may not be treating the diabetes, but you want to be working with that practitioner who is. Debridement could be the activity that you're doing for the wound. You want to look at the type of dressing that you're using. Surgical dressings themselves are submitted to the DME, or Durable Medical Equipment, MAC, Medicare Administrative Contractor. For providers in Iowa, Kansas, Missouri, and Nebraska, your DME MAC is Noridian. For Indiana and Michigan, your DME MAC is CGS. Both of these companies do have a local coverage determination and a local coverage article that applies to both jurisdictions concerning those surgical dressings. The LCD number is L33831. The LCA is A54563. And we provided the links to both of those policies in the chat function. Another thing to look at is, does the patient have an infection? Is this something that you're treating as a podiatrist, or is there another practitioner involved? Again, collaborate with them. You want to have that information from them on what is happening with that infection. A pre-submitted question that we had is, are podiatrists restricted, to specific procedure codes? Well, you want to look at the code descriptor for what you're doing. If, for an example, the code descriptor states trunk, for an example, then this is not the code you want to use as a podiatrist. Now, for the most part, podiatry covers care of the feet. We do have some of our states where the state requirements will also allow you to work on the hands. If that's the case, then you can certainly do that. And the procedure codes that you would use for that then would go along with the hands, not only just the feet. The next thing that we want to talk about is the active wound care management. And you can see we have the two procedure codes there, 97597 and 97598. These can be provided by the physician. They can also, however, be performed incident to the physician's service. So this would be by a nurse practitioner, etc. All of the normal incident to guidelines would apply. We just completed back in March a presentation on Incident 2, and you can find that again on our YouTube channel, on our webpage, and the title is Incident 2 Services. These procedure codes are listed by CMS as what they call sometimes therapy codes. So this means that if the services are being provided by a physical therapist, an occupational therapist, then the therapy thresholds and the therapy modifiers would apply. Those therapy modifiers would be the GP, GO, GN. This would also apply if the MD or the DO or the DPM or a non-physician practitioner or an incident to service, if they're acting under a therapy plan of care as opposed to the practitioner's plan of care, then you would also need to include those modifiers. You'll notice on here on your slide, for these two procedure codes, it indicates epidermis or dermis. This is the level of the debridement. These codes would not provide services or would not reflect services that would go deeper to that. There are additional procedure codes that you would use. The 97597 is for the first 20 centimeters or less. The 97598 is each additional 20 centimeters. So documentation then would need to support the debridement and the active wound care management that's being provided. The size that you would use, 20 centimeters or less, or each additional 20 centimeters, is for the total size of the service. And so what we mean by that is if you have multiple areas on the patient's foot where you're needing to do this debridement service, you would add up those surface areas of that wound, and then you would choose your appropriate procedure code. One of the questions that we have is a pre-submitted question that we had is, can the podiatrists themselves submit these two procedure codes? And the answer to that is yes. If their active wound care management is going to the epidermis or the dermis, then yes, they can submit these codes. The same questioner also asked about procedure code 97602. This particular procedure code is not payable by Medicare. On the Medicare physician fee schedule, this has a B as in boy status, meaning that it is always bundled into something else. So Medicare would not make payment for that. The next thing that we talk about here are the Incident to guidelines. And again, we have the Encore presentation for you. Documentation, if the service is being provided by someone other than the billing practitioner, documentation must show that it's being provided under the plan of care of that billing practitioner. So that could be the podiatrist, it could be a non-physician practitioner working with that podiatrist or in that same office. So Incident to services are going to be provided within the physician's office. This is going to be a place of service 11. You can also provide an Incident to service in a nursing facility, but not in a skilled nursing facility or a patient who is under skilled nursing facility care. Incident to also does not apply to a facility setting. This is in or outpatient hospital or a SNF. In or outpatient hospital, the hospital can actually submit for these services under the outpatient prospective payment system or the inpatient prospective payment system. Now, this presentation is not going to go into billing under OPPS or the IPPS. For the skilled nursing facility, this would be part of their skilled nursing facility charges. You'll also notice there that it says furnished under direct supervision. The billing practitioner must be within the office suite. They don't have to be in the same room, but they do have to be within the same office. During the PHE and during the waiver period, which is through the end of 2024, that direct supervision can be provided through audio-video communication. You want to indicate that within your documentation if your billing practitioner is not directly in the office while the service is being provided. There also has to be an employment relationship between that billing provider and the person who is actually doing the service. Now, this can be a W-2 employee. It could be someone that you have a contract with. It could be a leased employee, etc. If it's not a W-2 employee, then you would need to make sure you can put your hands on that contract or on that lease agreement should Medicare request that information. So here you can see that a definition of debridement. And debridement is the process of removing dead or icky or yucky diseased tissue in and around the wound bed itself. Now, there's different methods that you can use in order to accomplish that, and you want to document the type of debridement and how you have provided that service, what method you used within your documentation. We need to know how much tissue is being removed, from where, and with what method. The procedure codes demonstrating tissue removal could include the skin, full or partial thickness, subcutaneous tissue, muscle, and/or bone. You also want to document the character of the wound both before and after that debridement was done. This will include the pre and post wound dimensions, the descriptions of the tissue that has been removed, the amount, the color, the consistency, the odor, etc. You want to include the amount debrided in square centimeters. And then you also want to identify the status, I guess you could say, of that wound itself. So is it getting better? Is it getting worse? What does the wound look like? Is it black? Is it yellow? Is there pus coming out? Is there dead tissue, etc.? Active debridement must be performed under a certified treatment plan. That means that the practitioner who is overseeing this patient's care has determined the plan of care for this wound. As part of that, the treatment plan must be specific. What are your specific goals for this wound? Do you think that this wound is going to heal? Is this going to be a chronic wound? How are you going to, what's your plan of care for that? And then you can see there, the goals are going to be to remove that devitalized tissue, decrease the risk of infection, promote wound healing, and then, of course, prevent further complications. In your treatment plan, you also need to identify the frequency at which you believe that patient needs to receive the debridement. Now, this is your treatment plan. So you may run into situations with that treatment plan where you need to do something on a more frequent basis, which means you'll be updating that plan. Or the patient's wound is healing a lot better than you kind of expected, in which case you would update that treatment plan. The next information that we have then is talking about selective or non-selective debridement. What we have here are just the different types. So selective or non-selective then can be broken down into subcategories, and you can see that information here. I'm not going to spend a whole lot of time here because, again, those previous two webinars, our nurse analysts really went into a lot of detail on the difference between the selective and the non-selective. But we did want to provide you with this information. And again, the type of debridement is something that we would look for and is typically in the information that the providers are including within their procedure notes. So you want to make sure that that information is available. So what are some of the things that you need to have in your documentation? The documentation must clearly show that the criteria for the coverage indications and the medical necessity within that local coverage determination have been met. Your plan of care is going to include the information that's listed on your slide. So what's your plan? You want to document what you're doing for the wound. You want to document your short and long-term goals for this specific patient. You want to, do you want to complete healing of the wound? Is that what your expectation is? Are you providing treatment to prevent an amputation, etc.? What type of physician follow-up is needed? This could be, or could this require working with other physicians or practitioners to address issues that are contributing to this wound. There are new services available for 2020 or starting 2024. And maybe if the patient needs some additional assistance in taking care, in doing what they're supposed to be doing, taking care of the wound, then you could certainly work with that patient's primary care physician on caregiver training services. Depending on the nature of the wound, there are some additional services that you could provide to that patient. The plan should indicate the amount of debridement, the frequency, and then your estimation of the duration of your work toward getting that wound to heal. And again, does it have the potential to heal? Do you expect that it will heal, or do you expect that this is going to be a chronic issue for your patient? And of course, your documentation will support what you're doing with that. In addition to that, your documentation should show, is the plan working for the patient? Is the wound getting more shallow? Is it getting smaller? Is there less swelling or redness? Is there less pus or anything else coming from the wound? What is the patient's pain level, if appropriate? Some of your patients may not necessarily feel pain from that wound. You also want to document that. Does the treatment show that the patient is better to ambulate if it's a patient who can ambulate? You want to determine the wound status and document. Is it better? Is it the same? Is it getting worse, etc.? Because what you want to think about in your documentation is enough information in there so that if a nurse reviewer is looking at that, again, whether it's WPS or somebody else, they can tell what's happening. They can identify your plan. They can identify what you're doing for that patient, whether that patient wound is getting better, is getting worse, etc. Again, we can't see the patient. Additional documentation that you can include would be any appropriate modifications of your treatment plan. If you determine, just like we talked about, the wound is not getting better, you're going to try something else. You're going to increase the frequency, whatever it is you're doing. Then you need to update that plan. Your plan also needs to include information on what has already been tried and failed, and then the rationale, of course, behind those changes. The documentation would need to include information on any complicating factors. We go back to that optional or optimal rather, nutritional status. Is the patient maintaining their glucose control, etc.? Is there presence of an active infection in the wound? Are you able to treat that? Do you need to have an infectious disease specialist? All of that will be part of your plan. Is necrotic tissue present in the wound that might delay that wound healing process? And then what do you do about that? How is that going to be incorporated into your plan? And then, of course, you want to document measures taken to control those complicating factors. And again, if you're not the one who is addressing some of those complicating factors, then you do want to be working with that practitioner who is. And of course, if no one is, then you want to be talking to that patient about who their primary care provider is. When we're looking at wound care situations, we need to see the wound volume. This would be the wound dimensions pre and post treatment. This would help you to support evidence of improvement or lack thereof. Additional items that you could include with your documentation are photos that could show the transition of the wound. It can show where you started, where you are now, etc. I will have to just tell you, I am a certified professional coder, and as part of one of our AAPC chapter meetings, we had a lady who came in and did a presentation on wound care, and she provided pictures. I don't envy what you guys are doing in taking care of these wounds, in having to look at those pictures in order to code appropriately based on the documentation. So I admire you for what you're able to do here. We would expect improvement. That's kind of what Medicare is looking for, a decrease in the volume and the surface dimensions of the wound itself. Other signs of improvement could be decreased drainage, inflammation or swelling, changes to the wound dimensions, or reduced necrotic tissue. We'll talk a little bit more about this in the next few slides. When we're looking at measurable signs of healing, the wound size should be documented for each service that's provided. So you don't want to simply have in your medical record the documentation of the size of the wound at the start. For each of the services that you're providing, you need to document that information within the medical record. This allows you and Medicare, should we request your documentation, to see the changes. It also allows you and Medicare to see whether the treatment is actually working for that patient. What's the plan? What's the size? Our first error that we'll talk about is in missing or unclear documentation of the measurable signs of healing. A common question we receive regarding documentation is, does potential to heal documentation have to be specific in regards to good, fair, or poor language? Or does the documentation that a wound is anticipated to heal in 3 or 4 weeks meet this criteria? Both of these options will help support the provider's kind of thought processes on the potential to heal. Rating it with a good, fair, poor, or the length of time will help support the medical necessity of the care. A reviewer, and again, these are nurse reviewers, can usually gauge potential to heal based on the information within that documentation. But a clear potential to heal stated in the documentation will make for a smoother review. Some of the other areas of documentation errors that we have seen is the pre and post wound measurements. Each service, again, like I said, has to have the size of the wound, and this would include both the surface area and the depth. Our next most common error is missing or insufficient treatment goals for each of the wounds that you're taking care of. If the patient has more than one wound that you're dealing with, then documentation must be specific for each of those different wounds. The plan of care should indicate information on how the goal will be achieved. Goals are really important for the big overall picture of what you're trying to accomplish for that patient. Your documentation should include the progress toward that goal, and if there isn't any progress, then why? And what are you doing? What is your physician or practitioner doing to change or modify that goal? Again, address any issues that could be inhibiting that wound healing. You want to give that big picture again so that a reviewer or another clinician can really understand what's going on with that patient and the wound in question. You want to be specific in your plan. For an example, you want to decrease the wound in size by 20% within 3 weeks. And then what are the provider and patient activities in order to accomplish that? Now, this slide information that we have, that there are some procedure codes and there are some that would apply to podiatry specific also. CMS has designated as inpatient only. So that means that they cannot be done in the office. They would have to be done either in an ambulatory surgical center, in an outpatient department of a hospital under the OPPS or Outpatient Prospective Payment System reimbursement, or as an inpatient. We do have a link in the resources section to that list, and this can change every year. So you do want to take a look at that. The next thing that we want to talk about is hyperbaric oxygen therapy. We have a link for you in the resource section to the National Coverage Determination 20.29 for this. Now, we have just a couple of the covered conditions listed on your slide. This is not a complete list, but this is what we pulled out as more specific to podiatrists as opposed to other type of providers. Diabetic wounds, of course, are listed here, and you see that if it's a diabetic wound, then you need to have this additional information. You need to identify the type of diabetes, the wound itself, and how it is classified. Documentation in the medical record would also need to show the previous treatment that the patient has received and that has failed, and why that failed. If the previous treatment was provided by somebody else, you will need to work with that practitioner to get that information. And then we have information on the wound requirements themselves. And this again goes back to your documentation. You can see here on the slide, you would also consider the standard wound therapy in addition to the HBO therapy. You want to document the evaluation of the wound at least every 30 days, and you want to watch for signs of healing. If there are no measurable signs of healing within that 30-day period, then Medicare would no longer reimburse for this. The next thing that we want to talk to you about is skin substitutes. The FDA package is probably going to identify these as single use. If the FDA packaging instructions do identify it that way, then in your documentation, you need to identify the amount that is being administered to that patient. Plus, you want to identify any amount that has to be discarded, that can't be repackaged or used on another patient. If you have discarded skin substitutes, then you would need to use two lines of service. One is the JW. This is the amount that was provided to that patient. And then the second line would use the GZ modifier to identify the amount that has been discarded. If you use the entire package, then you would simply have one line of service with that JZ modifier. These are the procedure codes A2001 through A2010, and these are carrier priced. You can see information there on the bottom about a CMS town hall meeting that they held January 18th, and that link will take you to that recording and to the transcript of that. CMS has published information in the MLN Connects, and they published this on April 4th, about new LCDs for skin substitutes. This will be it won't be a national coverage determination, but it will be a local coverage determination that all of the MACs have worked on together. We do have an open draft LCD meeting that will be coming up on 5/22 of this month. You can register for this and provide any comments that you have on this policy. Jennifer did place the link to register for this meeting in the chat, and we have the draft LCD in process. So you can go to our website. You can find the information to register to attend the open meeting. You can also find information where you can provide information back to us with any comments that you have on that particular draft policy. Our medical directors and policy staff then will take that information back. We'll make decisions based on the information that you're providing to them, and then eventually there will be a final policy for that. We also wanted to provide you links for the National Correct Coding Initiative. In choosing your procedure codes, you want to take a look for the procedure to procedure edits. One of the questions that we get is, what if I'm doing the same or different services on two different parts of the patient's foot? Well, you want to take a look at those procedure to procedure edits to determine whether or not a modifier would apply. And then also for your units of service, you want to take a look at that medically unlikely edits. We do have YouTube presentations on both of these topics that you can take a look at. So the next thing that we have then for you are the resources. We have the WPS Encore page, which is actually on our website. We also have the YouTube channel, and these are the titles of the 2 webinars I told you about that our nurse analyst did. We have information on the results from our targeted probe and educate on wound care that's available on our website. We have links for you for both of the LCD, local coverage determination, and then also the local coverage article. The top resource listed there for you is on Incident 2. We've got a link for you to the national coverage determination on the hyperbaric oxygen therapy. And then we have a link for you on those inpatient only codes. Now the addendum E is a zipped file. So when you go into that link that's there, you will have to unzip that in order to actually get to that file. And then the last thing there is simply how to use the National Correct Coding Initiative tools. So the next thing that we're going to have is we'll be able to talk about some questions. One of the things that I want to bring to your attention, we talked about the surgical dressing policy. CMS published information in their MLN Connect on March 4th that there is an OIG report, or Office of Inspector General report, showing that the improper payment rate for surgical dressings was over 40%. That's $116 million in a projected error. Medicare has compliance tips that can assist, and we'll place that link for you in the chat. These are the supplies that would be billed over to the DME MAC. Again, take a look at some of those compliance tips, really pay attention to those LCDs. We had a pre-submitted question on wound vacs. We did not include that in this particular presentation. If you want education specifically on that, then we advise you to indicate that within your survey. We also had a question on routine foot care. We did a presentation on that on Tuesday on 5/7, and this will be available as an encore within the next week or so. We also had a question, and this one really kind of concerns me, but the question said the podiatrist is receiving requests from chiropractors to order x-rays. Well, don't do that. Okay, let me just tell you, don't do that. If you're ordering an x-ray, What you're telling Medicare is that you need that x-ray in order to treat your patient, and that you're going to be using the results of that x-ray in the treatment plan for your patient. Chiropractors, of course, are mainly dealing with the back. A podiatrist would not be treating the back. So if you're getting those types of requests, please don't order the x-ray, and you really need to contact our complaint screening department with the request that you have received. Another pre-submitted question is, what do we do for bundled services on the same foot? Well, there's a couple of things that you want to look at there. If it's the same service, then you want to be combining those sizes. So if you're going the same depth, then you'll simply increase the surface area to encompass both of those wounds, and then choose the appropriate procedure code that goes along with that size. You can also take a look at using the laterality, right or left, or the toe modifiers if appropriate. And then you want to look at the NCCI guidelines that we talked about for possible other modifiers. Otherwise, it is not separately payable if it's considered a bundled service. So now we'll go ahead and open it up for questions. Jennifer, do we have any?
Yes, we do have one question. Medicare requires that we report all services rendered. How do we report when a provider does debridement of square centimeters that are in excess of MUE? If we add all units of the debridement code to the claim, for example, 13 units of 11045, then Medicare denies the entire amount instead of just paying for the 12 MUE units allowed.
Okay, what you want to do in this situation, number one, is really kind of pay attention to the surface area, the square centimeters. But when you're submitting that claim to Medicare and you know that there is an MUE that applies, you want to submit 2 lines. So you'll submit the first line with the total number of MUEs that Medicare will allow. Then you do the second line with any additional services. When we deny those additional services, it will deny with appeal rights. So you can certainly submit documentation and request an appeal on those additional services. Next question.
That's all the questions we have in the chat.
Okay. So Jennifer, I'll ask again if we have an additional question.
Yes, we do have a follow-up to the question we asked. She asked, does the second line with units in excess of MUE require any modifier?
No, it would not require a modifier. The particular modifiers that could be used really wouldn't apply to the specific procedure codes. Because it's on the same claim, Medicare is not going to deny that as a duplicate. It will be denied as exceeding the MUEs.
And that's our only other question.
Okay. Then on behalf of Jennifer and myself, we want to thank you very much for attending today. Again, just as a reminder, if you have questions or comments, you can certainly submit those back to us. And again, we really do encourage you to take that survey. We're interested in your feedback. If there's a way that we can do education better and you want to provide that to us, then we would be very excited to look into that. And then, of course, you have the area of the survey where you can tell us what additional education you're interested in. So thank you very much, and you guys have an absolute great day. You can now disconnect.